Hi, everyone. Today we're going to be going over the genetics of autism spectrum disorder. So the learning objectives for today are going to understand the clinical diagnosis of autism spectrum disorder, to identify several genetic causes of autism spectrum disorder, and to learn the genetic approach to autism spectrum disorder. So the outline, first we're going to go over an overview of autism spectrum disorder. Then we're going to talk about some genetic causes of autism spectrum disorder. And lastly, we're going to go over the clinical genetics evaluation of autism spectrum disorder. So what is autism? This refers to a broad range of conditions that's characterized by challenges with social skills, repetitive behaviors, speech, and nonverbal communication. It's estimated to affect about every 1 in 44 children in the United States, and it can be influenced by genetic and environmental factors. There are often other sensory sensitivities and medical issues that we see with autism. So things like motor abnormalities, GI disorders, constipation, diarrhea, seizures, or sleep disorders. We can see those quite frequently, as well as other mental health challenges. So things like attention deficit hyperactivity disorder, anxiety, OCD, things along those lines. So signs of autism usually appear around 2 to 3 years old. And some of the developmental delays can appear earlier. So sometimes kids with autism can have developmental delays. It's not necessarily that it always has to happen. But, for signs of speech delay, the kids aren't necessarily responding to their name or saying words on time. So our rule of thumb is to expect single word phrases from kids at 1 year old and 2-word phrases at 2 years old. And sometimes we can get delays prior to then. We do know that early intervention in kids with autism leads to the best possible outcomes. So these are things like physical therapy or PT, occupational therapy or OT, speech therapy, and applied behavioral analysis. So that is a type of therapy that we do use in kids, or we don't use it specifically as genetics professionals, but as a medical community, they really recommend ABA therapy to help kids with autism. And it's a very intensive therapy that focuses on learning behaviors. And these kids have it, 40 hours a week. So they really do get immersed in it. But we've seen amazing outcomes in kids who get a lot of ABA therapy and other therapies. So for the diagnosis criteria for autism, kids or individuals have to meet all 3 of these findings in order to be diagnosed, as well as from the following slide or the next slide. So to be diagnosed with autism spectrum disorder, someone has to have persistent deficits in social communication and social interaction across multiple contexts, as manifested by the following, either currently or historically. So the first one is deficits in social emotional reciprocity that can range from abnormal social approach and failure of normal back and forth conversation to reduced sharing of interest or emotions or affect to failure to initiate to respond to social interactions. The next one is deficits in nonverbal communicative behaviors that's used for social interactions. This can range from poorly integrated verbal and nonverbal communication to abnormalities in eye contact and body language, or deficits in understanding and using gestures, to a total lack of facial expressions and nonverbal communication. And lastly, individuals have to have deficits in developing, maintaining, understanding relationships that can range from difficulties adjusting behavior to suit various social contexts, to difficulties sharing imaginative play or making friends, to absence of the interest in peers or having friends. So again, kids need to have all 3 of these findings. And then they also need to have 2 of the following from this slide. And so they also need to have either stereotyped or repetitive motor movements, use of objects or speech. So this is things like simple motor stereotypes. So like, hand flapping or something with like that, lining up toys or flipping objects, echolalia, which is repeating what people say, or idiosyncratic phrases. They can have insistence on sameness, inflexible adherence to routines, or ritualized patterns of verbalized or nonverbal behavior. So this is things like extreme distress at small changes, difficulties with transitions, rigid thinking patterns, grading rituals, need to take the same route or eat the same exact food every single day. They can have highly restricted, fixated interests that are abnormal in intensity or focus. So, like an example would be a strong attachment or preoccupation with unusual objects, excessively circumscribed or perseverating on interest. And lastly, they can have hyper or hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. So this is things like apparent indifference to pain and temperature, adverse response to specific sounds or textures, excessive smelling or touching of objects, and visual fascination with lights or movements. So again, kids need to have all three from this slide, but then they need to have 2 or the 4 of this criteria in order to be diagnosed with a clinical diagnosis of autism spectrum disorder. It's important to note that autism is a clinical diagnosis. A lot of patients come into clinic saying, can you diagnose my patient with autism? And we can't by doing genetic testing. So we would typically refer them to either a developmental pediatrician, a neurologist, or a neuropsychologist to give them that diagnosis. What we do as genetics professionals is we see if there is a genetic explanation for a child's autism diagnosis. So what are the causes of autism spectrum disorder? Autism is a genetically heterogeneous disorder. There are many different genetic causes, many different factors that go into it. It's estimated now that it's about 30 to 40% of patients with autism actually have an identifiable genetic cause, which is incredibly high. And this can be, there's single gene causes, copy number variations, epigenetic alterations, increased susceptibility genes. So there's really many, many different causes of autism from a genetic standpoint. So first, we're going to talk about copy number variants, and 2 of the most common are 16p11.2 deletion. This accounts for about 1% of cases of patients who have autism. That being said, only 25% of the patients with the deletion exhibit a phenotype. So there is variable expressivity and incomplete penetrance. The other copy number variant that we're going to talk about is 15q11.2 deletion, specifically from breakpoints 1 to breakpoint 2. And this deletion is actually found in about a half to just a little above 1% of microarrays that are done. So it's about a 2 to 4 fold increase compared to other CNVs. So starting with the 16p11.2 deletion, clinical features can include developmental delay that varies in severity significantly. So some of the delays that can happen are, motor coordination issues that occurs in about 60%, motor speech disorders. So things like apraxia, which is difficulties making accurate movements when you're speaking, dysarthria, which is difficulties controlling the muscles when you need to speak. So it makes the kids or individuals hard to understand. So the motor speech disorders are present in about 80%. They're usually mild to moderate, but there can be some severe. And then they can also have language disorder. So both receptive, so understanding language delay, and expressive, which is, expressing your language and what you want to say. So most of these patients or individuals with this deletion do not have intellectual disability though. And there's also an increased risk of psychiatric conditions. So these individuals can have ADD or ADHD, and that's found in about 35% of patients. They can have autism, which is what we're talking about, and it's found in about 25% of patients with the deletion. And then some other, psychiatric concerns. So anxiety disorders, OCD, which is obsessive compulsive disorder, ODD, which is oppositional defiant disorder, schizophrenia, but these, they're not above the general population frequency. We just do tend to see it as we do in the general population. So other features that we can see are seizures, vertebral anomalies, which are anomalies of the vertebrae in the spine. There can be hearing impairments, both sensory, neural, and conductive. They can have macrocephaly, which is a larger head. They can have some cardiovascular malformations. And there is a risk for obesity, which is seen in about 75% of patients with 16p11.2 deletion. And this generally emerges in childhood. So it's something to keep an eye out. Okay, moving on to the next copy number variant. We're going to go over 15q11.2, which is BP1 to BP2, breakpoint 1 to breakpoint 2 deletion. So it's caused by a deletion of 15q11.2. At this region, so on chromosome 15, there are 5 breakpoint sites. Which it's basically these breakpoints are a cluster of low copy repeats that lead to the non-allelic homologous recombination. And so, you might have, from the previous lecture, this is the same region as Prader-Willi syndrome and Angelman syndrome, but these two conditions are caused by a deletion of BP1 to BP3. So as you can see in the schematic on the right, this here is chromosome 15. Here is the portion that we're looking at, the Q11.2 to all the way down to, it looks like 13.3-ish. So this is the area that's deleted in the 15q11.2 deletion that we're talking about, BP1 to BP2, where the deletions causing Prader-Willi syndrome and Angelman syndrome are much bigger and include this BP3. So you can see there's BP3. And it's thought that these 4 genes, the GCP5, CYFIP1, NIPA2, and NIPA1, they're thought to impact the severity. So they are biallelically expressed, so they're not involved in the imprinting that we usually see in Prader-Willi syndrome and Angelman syndrome, and they are expressed in the nervous system. So I think that's what they think can lead to some of the severity and range of severity. This deletion does have incomplete penetrance, and the penetrance is estimated to be about 10%. And again, it has variable expressivity. So not everyone who has the deletion has every single clinical features. This can be either de novo or inherited. About 50% of the times it's inherited from an unaffected parent, and 35% of the time it's inherited from an affected parent. And the de novo rate, they estimate between 5 and 22%, which is kind of a big range for estimating. So the clinical features of 15q11.2 deletion, they can have developmental delay, speech delay, microcephaly. They can have really nonspecific facial dysmorphisms, but the most common are palatal anomalies. And then they could also have some behavioral features. So things like ADD, ADHD, autism, OCD, self-injurious behaviors. So, injuring themselves. ODD, oppositional defiant disorder, which that is essentially when the kids or individuals are cranky and have an angry mood and tend to be defiant against authority figures. And then we can also see schizophrenia in patients with this deletion. Okay, moving on to sequencing variants. Right now, there's over 1,000 genes that have autism spectrum disorder as a clinical feature that can be seen when there are changes in that gene. So it's a huge, huge list. So things that we like to think about, is the autism an isolated feature, or is there, a major malformation, a heart defect, a brain anomaly, anything else? does the kid look dysmorphic or not? So those are things we think about to kind of narrow our way down on what to send. There are many, many labs that have varying size of autism panels. It can be from tens to hundreds to thousands of genes that can be on these panels. And some do use an exome backbone. So they do, sequence the exome, but then focus on the genes that are associated with autism. And they do ask for parent samples to help, with the interpretation. So that gets us to, coming up with the differential is super important. So, again, isolated autism, is there anything else we need to be thinking about? What else is going on with the patient? So the first condition we're going to talk about is P10 hamartoma tumor syndrome. This is caused by pathogenic variants in a gene called P10, and changes in this gene are found in about 10 to 20% of patients that have both autism and macrocephaly. P10 is a tumor suppressor gene, so that's what they think leads to the overgrowth and the increased growth in the head size. If you think about it, they have one less tumor suppressor telling, stop growth, so then it grows. It does cause a spectrum of conditions. So it can cause, Cowden syndrome, or it's something called Banyan-Riley-Ruvalcaba syndrome. And so P10 hamartoma tumor syndrome, Cowden syndrome typically presents in adulthood. And this is characterized by macrocephaly, so a large head size, characteristic skin lesions, which can include, so there can be some trichomonas, acral keratoses, some mucocutaneous neuromas, and then lipomas. There are benign hamartomas, which hamartomas are just benign growths that are made up of an abnormal mixture of cells and tissues that are found typically where the growths are. And there's also an increased risk for certain cancers. So there's an increased risk for breast, uterine, and thyroid. So that's important. You might see some of these patients in cancer clinic. And then Banyan-Riley-Ruvalcaba syndrome typically presents in childhood, and it's characterized by macrocephaly, hamartomas, and then penile freckling in males. So this is very important for the physical exam. Whenever you see a patient with macrocephaly and autism, the geneticist will, look at their genitalia to see if there's any freckling. And these kids can also have, or individuals can have, developmental delay, intellectual disability, and autism. There is the risk for thyroid cancer does start in childhood. So starting at 10 years old, they do recommend a yearly neck palpitation. So just to feel that the thyroid, see if they can feel anything. And then a thyroid ultrasound beginning at 10, that happens every 3 years. Okay, the next condition we're going to talk about is Rett syndrome, and this is caused by pathogenic variants in a gene called MECP2. It's inherited in an X-linked manner. Females, I forgot to mention that P10 is inherited in an autosomal dominant manner. So going back to Rett syndrome, females can have a phenotype that ranges from classic Rett syndrome to variant Rett syndrome, which we're going to go over in the next slide. And males, they do have severe neonatal onset encephalopathy, and death often occurs before 2 years old. So males have a much more severe phenotype than females. So the clinical features of Rett syndrome, classic Rett syndrome is, when the kids have a partial or complete loss of acquired purposeful hand skills. They can have partial or complete loss of acquired spoken language skills or language skills. They can have gait abnormalities, so they tend to be ataxic, which is just a very uncoordinated gait. And then they can have stereotypic hand movements. So things like hand wringing and squeezing and clapping and tapping, as well as putting their hands in their mouths. And so it's a progressive neurodevelopmental disorder, and it leads to this loss of the motor skills and language skills. So it's an incredibly devastating diagnosis. Kids, the parents, they have a typical developing kid until around, or probably 6 months to a year. And then they notice that some of the kids, they're not necessarily meeting all their milestones, so they start to lose interest in certain things. And then, between 1 and 4 years old is when there's that rapid decrease in skills, and then it tends to plateau. And then later on, after 10 years old, they can have motor deterioration, and it's usually because of more deterioration, that they can decrease their mobility and walking skills, and then muscle weakness as well. So there's also variant Rett syndrome, which this is just characterized by mild and non-progressive learning disability. So it can range from this classic Rett syndrome to this variant Rett syndrome. And I'm going to show you guys a video of a patient with Rett syndrome, just so you can kind of see how they function, and kind of their hand movements.
In October 93.
And you can hear that, she was typical, and then it's this progressive
syndrome. It's just a random genetic mutation. They don't know why the mutation happens, even though they found it. Rett girls are born normally, like any other child, and start to develop normally, like any other child. She was just a really cruisy baby. Just
you can
lovely.
see no speech skills.
Between 6-9 months and 2 years old,
hand skills.
They all have a period of regression. So whatever skills they gained, you'll notice a drop off. Yeah. It's not hereditary. Then there's one Rett girl born every 5 minutes. Most of the girls, Rett syndrome is an X chromosome mutation, so the girls have 2 copies of X. The boys have only X and a Y.
And you can see she has, difficulties with her.
There is a few
her motor skills, and she's probably at the motor deterioration. And so it's difficult for her to walk.
I've been
and this very ataxic, unsteady gait.
2.5 years. Working with people like Sarah.
All right, so now we are going to move back on to the male version of Rett syndrome. So males who have Rett syndrome have a severe neonatal encephalopathy, and this is characterized by microcephaly, so with small head size. They have this relentless course that follows a metabolic degenerative type pattern. So it's very similar to the metabolic decompensation that you see in kids with metabolic disorders. They can have abnormal tones, involuntary movements, severe seizures, and breathing abnormalities. So they can have central apnea. And then the other type of Rett syndrome in males can just be severe intellectual disability. And this is characterized by moderate to severe intellectual disability. They have a resting tremor, which is just a tremor at baseline. They can have some slowness in their movements and ataxia. They have PPMX syndrome, which is pyramidal signs, Parkinsonism, and macroorchidism. And pyramidal signs are, things like spasticity, weakness, hyperreflexia, and it can be increased muscle tone. They don't have seizures or microcephaly, and they usually have normal imaging studies. So a normal brain MRI, a normal EEG, which is an electroencephalogram, and that can measure or track seizures or look for seizures. And then an EMG, which is an electromyography, which that looks at the muscles. Okay, and now moving on to other causes of autism spectrum disorder. There are other genetic causes. So the next one we're going to talk about is Fragile X syndrome. This is the most common cause of autism in males, and it's caused by a CGG repeat expansion in the FMR1 gene. It's estimated to be present in about every 1 in 7,000 males and every 1 in 11,000 females, and it does have X-linked inheritance. So as I mentioned, Fragile X is caused by a CGG repeat expansion in the FMR1 gene. The normal number of repeats to have is 5 to 54. The intermediate is 45 to 54. And sometimes in this range, the repeats can expand slightly, but it'll be, 45 to 47 or 45 to 50. We consider pre-mutation carriers 55 to 200 repeats, and the risk associated with this is that these individuals can develop Fragile X associated disorders. So this is things like for FXPOI or Fragile X syndrome primary ovarian insufficiency, which is the loss of normal ovarian function. And it typically occurs, before 40. And so these individuals can, or these women can undergo menopause quite early. And the FXPOI happens in about 20% of women with the pre-mutation. FXTAS is Fragile X associated tremor ataxia syndrome, which is an adult onset neurodegenerative disorder. And it's really characterized by problems with movement and thinking ability. So it's a cerebellar ataxia with an intention tremor. So again, ataxia is that unsteadiness and uncoordinated. And that intention tremor is, a tremor when you are going to do something. So a tremor that happens, when you go to pick up your water bottle. About 40% of males with the pre-mutation carrier will develop FXTAS, whereas only 16 to 20% of the females with the pre-mutation will develop it. And then the full mutation is when there is 200 or more repeats. So this is just a table of the risk of expansion. So as you can see, it's not like that, if there is a pre-mutation or, it will certainly expand to the full mutation. If there's the lower the amount, the lower the chance to expand to a full mutation. So as you can see, if there's 100 to 40 to 199, it's almost 100% going to expand to the full mutation. But up here, we see a lot of patients with, coming in for 56 repeats or 67, and they have a 3% risk or a 4%-ish and a 5%. So it's a fairly small chance to increase, but it can. So that can be reassuring to some families. So the clinical features of Fragile X syndrome, there are the physical features that become more apparent with age. This includes a long and narrow face with large ears, a prominent jaw and forehead. They can have joint laxity, so their joints tend to be flexible, and macroorchidism in males, which is an increase in the testicular size. They can have intellectual disability or learning difficulties. They often have motor coordination issues. They can have behavioral problems. They can have autism, and they can have also other medical issues. So seizures, strabismus, which that's that misalignment of the eyes, otitis media, which is often just frequent ear infections. They can have gastroesophageal reflux and sleep apnea. So the clinical genetics, so for Fragile X testing, how you pick it up, there is specific Fragile X testing that looks at the repeat numbers, the repeat size for you. So you would send a specific Fragile X test. As far as the clinical genetics approach, as always, you want to take a thorough pregnancy and birth history, developmental history, family, and medical history. A physical exam is super important for things if you see a big head and freckling of the penis, that will lean you one way. If you see a small head, that might lean you another. So physical exams are very important. And then as far as testing goes, the first tier testing for any patient with autism is to send a SNP array and Fragile X testing. But we can send, if insurance doesn't approve a panel right away or exome sequencing right away, it's always good to start with those two. The panels are huge. Some of them are, and some of them are more targeted. So, it's certainly warranted to send a panel. And then if all of that comes back normal, I think it's definitely, worthwhile to consider exome sequencing. The exome is becoming more common for patients with autism, even isolated autism, due to the increased yield in it. Okay, so that is all for our autism lecture. If you guys have any questions, feel free to reach out. And if not, we'll talk more in class. Thank you.